Hello, everyone, and welcome to the second public of the campaign for an All-Ireland NHS. My name's Goretti, and I'm a member of the organising committee of the campaign, and I'll be chairing tonight's meeting, where we hope to discuss some of the most important lessons of the COVID-19 pandemic so far, and how the present moment is a really unique one, where there's a possibility for a single-tier All-Ireland National Health Service. And I think the pandemic, if anything, has shown us not only that this is possible, not only that it's possible to transform the way that we're for people, but that it's actually necessary to do so, and to do so quite rapidly. So joining me tonight to discuss this moment and how we move forward as a campaign, we have a really exciting panel of speakers. So first of all, we have Professor Veronica O'Keane. Veronica is a professor of psychiatry in Trinity College Dublin and a practicing psychiatrist in Tally University Hospital. So Veronica has been involved in numerous campaigns for health justice and reproductive rights, and she is a leading choice group in the run-up to the 2018 repeal referendum. After Veronica, we have Goretti Horgan. Goretti is a member of our campaign organising committee and a long-standing socialist and trade union activist from Derry. Goretti is also a lecturer in social policy at the University of Ulster in Jordanstown and has written extensively about inequalities, health policy and the social determinants of health. So we might hear a bit about that tonight from Goretti. Also have with us, hopefully soon, Dr. Des Shearer. Des is a doctor who's worked in both services on this island, in the HSE and in the Health and Social Care Service in the North. At the minute, he's working as an emergency medicine doctor in the Ulster Hospital in Dundonald, where he's an active trade unionist involved with the BMA and also still the IMO, if I'm not mistaken. And finally, we're very pleased to be joined by Dr. Lee Humber as well. Lee is a health and social care academic and author of the recent book, Vital Signs, The Deadly Costs of Health Inequality. And he's also an active trade unionist and socialist activist. I really implore people, if you're interested in the topic, to check out his book. And Lee will speak tonight on the history of the foundation of the NHS and how it was born out of a moment of emergency similar to the one we find ourselves in now. So before I go to Goretti, who will speak first tonight, I'd like to invite people to leave tonight their comments and contributions in the comment section. After all of our speakers have come in, I'll take some of those questions and put them to our panel. So we also have one last thing to promote, and that is our sign-up sheet. So our sign-up sheet should be pinned in the comment section of this live stream. And really, we'd implore you, because we're not just a group that wants to talk about the National Health Service. We're a group that wants to organise and put pressure on both states, North and South, to roll out All Ireland Health Service. So fill that in, and we'll be back in touch with you about how you can be involved. We have an organising committee that's been meeting pretty regularly, and we also want to move towards more regional groups to really get this campaign off the ground in the weeks and months ahead. So without further ado, I'll hand over to Goretti Horgan, who's going to speak first.
Hi. So I suppose I thought that I would start by talking a little bit about why we need an All-Ireland NHS and why it is that we're bothering to campaign about it. So there's been a lot of talk about the failures that we've seen in the health services during the COVID-19 crisis and scandal. So the scandal of how poorly our health services, North and South, were actually prepared for the crisis. But what we haven't really talked about so much is about all of the underlying ill health that's actually contributed to the death rates North and South. And if we look across the island of Ireland, we can see that the inequalities, that the gap between the rich and the poor is reflected also in our the statistics are really kind of So they're shocking north. In the north, they're particularly bad. So, for example, we know that if you look at the figures from the CSO in the south in relation to health inequalities in the 26 counties, we know that men who are living in the least deprived areas live about 5 years longer than men in the most deprived areas. And don't even get me starting to talk about traveller men, because they basically, their life expectancy is what the settled communities was about 50 years ago. And similarly, with females, the gap between females in terms of health inequalities isn't as great, but it's still shocking that people die younger just because of deprivation. Now, that's bad enough in the south, but when we look in the north, it is absolutely shocking. There's about a 7-year difference between the life expectancy that a man will have in the most deprived area compared to the least deprived area. And when we look at actually figures that I can't get for the south, which is healthy life expectancy at birth, and by the areas that the deprived areas that people are living in, which means, like, in other words, what age can you expect to live to without acquiring a limiting disability or health condition or poor health condition. And whereas in England, in Scotland, in Wales, a man can expect to live basically to his mid-50s before he develops, in the poorest areas, live to their mid-50s before he'll start to have a disability or ill health. And in the north, it's actually just over 50 years of age. You're actually and in the area, in the areas like Oxide and the Brandywell, it's even worse. So so when we look at that, and actually for women in the north, it's almost as bad. The difference between the healthy life expectancy at birth for a man in the north of Ireland is literally 14 years less for somebody living in the most deprived areas. I've got to very quickly just say that this is not an area effect. This has got nothing to do with, that there's it's like something about that particular area. It's got to do with poverty. I can tell you that because I live in one of the most deprived wards in the north, in the Belfast area here, and myself and my partner actually confound the statistics for the area precisely because we've actually because we don't struggle to put bread on the table on an everyday basis. We both got decent jobs, and when we look at why it is that there's those levels of differentials between the better off and the less well off in society, there's actually something that you might want to Google, which is really worth knowing about, and that is these top 10 tips. Now, I am not sure actually how I can, if I show you these, but I'll talk to you about it instead. If you go on to the Chief Medical Officer for North or South and see what they're saying that you need to do in order to improve your health, they'll say things like, don't smoke if you can't stop smoking, well, then at least cut down, have a balanced diet, plenty of fruit and vegetables, keep physically active, and all those kind of things. Well, actually, the reality is that if you're that the stress that you face on a day-to-day basis, just from struggling to make ends meet, that stress is actually worth. Is actually
I agree.
Worth. Yeah, I'm actually just seeing these things in the side to say that there's problems with.
Yeah,
Me, yeah.
Yeah, I think there might be some difficulties with your connection, Goretti. Would it be possible for you to move maybe closer to the router, and maybe I can go to another speaker and then come back to you?
I'm actually very close to the router. I am actually very close to the router, but I can. I mean, literally, the router is like is 10 feet from me.
It's actually working perfectly now. Now that we've stopped, it seems to be working much better. You're perfectly clear there. Sorry to intervene. I think you're clear now.
Okay, so shall I resume? Yeah.
Yeah, if you want to.
Okay, so yeah, okay. Well, I won't say very much more. I think that whenever the National Health Service was set up in Britain, and I know that he's going to talk more about this, that one of the whole points about it was to maintain a healthy that the population would be healthy. And one of the things that we've learned in recent decades is that everywhere in the world that we look, the bigger the gap between the rich and the poor, the greater the poor health. Every aspect of health, whether it's mental health or physical health, if the gap between the rich and the poor tells us a lot about what the health of the population is going to be like. And that is, like I say, particularly clear across the island. Here in the north, we can actually see more clearly the way in which higher levels of inequality, of income inequality, bring higher levels of health inequalities. It's a bit less opaque in the south because, like, the north is so small, we can really see, like, from one area to the next very clearly, just how the income inequality in our society actually impacts on our health. So when we're talking about the need for an all-island NHS, we also have to look at looking for an all-island situation where we won't have the huge gaps between the rich and the poor that mean that a child who's born into a poor family is going to have poor health, even before they get to school, and who'll actually, things like I think something like 40 or 14 times more likely to die in a cot death. If you're here in the north, these are actually Department of Health and the North figures. If you're born into a deprived area, than if you're born in one of the better off areas. So listen, I leave it at that because I said at the start that I'm feeling unwell. I'm a bit like that minister in Parliament the other day. I'm starting to kind of feel a bit sweaty, and my stomach isn't too good, so I might have to pop off to get a test.
Thank you, Goretti, for that really interesting introduction to the meeting, and certainly this broader conception of health that you mentioned that takes into account the structural and social determinants of health is something that I think needs to be a fundamental part of a foundational part of an all-Ireland National Health Service as we look to move towards that kind of. So next up tonight, we actually want to go to someone who has been on, I guess, the front lines of this crisis, working as a doctor in the Ulster Hospital in Dundonald. I mentioned Des earlier on has a kind of unique insight, having worked in the system in the south and the system in the north. So hopefully Des will be able to give us a little bit of insight from inside the system, that will kind of lead us to, I guess, the conclusion that we need a better all-Ireland system. So over to you, Des.
Hi guys, can you hear me? Guys, a little bit of trouble earlier with microphones and stuff, so I hope you can hear me. Great. Okay, so yeah, as Conor was saying, like, I've only been a doctor for nearly three years now. It doesn't sound like much, but I started off in the south working in Limerick in the emergency department. I did my internship there, and then I moved up to Belfast because family circumstances changed. My dad was unwell. He's doing okay now, so that's great. But I'm working in the emergency department up here now in the Ulster Hospital. And so about a year ago, I wrote a letter in support of protests while I was in Limerick because of the crisis that the health service was in down there. And to be honest, it's still in. And unfortunately, when I moved back up to Belfast, the exact same thing is happening in the health service here. Emergency departments are overcrowded, wards are overcrowded, there's not enough beds, we've got trolley waits, we're short-staffed. And, people try and give excuses of why emergency departments are overcrowded, and they'll say people aren't using the health service properly, they're not seeing their GPs, or they're not getting this or that. But it's not their fault. If patients are coming to the emergency department, it's because they've nowhere else to go, and that's because something has failed within the health service and they can't get the access and they can't get the help that they need. And we're seeing the exact same problems in the emergency departments and in the hospitals in the south and in the north. It's the same issues. And I'm not going to go to the politics of this, but we really do need a health system on this island for everyone on this island. There's no point in splitting it in the middle or splitting it into four, a health service for each province. It's not going to work. We need one for the entire island, because people come in the door and they need the same thing because they're having the same problems, whether they're in County Limerick or County Antrim or in the middle of the country. Like, they need the help, and we're trying to give it to them as best as we can, whether it's a medical issue or a mental health issue or a social issue. They all come to the hospital for help. And it doesn't matter what colour your favourite flag is, or what colour your skin is, or what God you believe in or don't believe in. Everyone has the same issues, and there's no reason why we shouldn't have a health system to help everyone on this island with exactly what they need. And to be honest, there's no point in making it even more complicated. We need to boil it down to as simple as can be. We're all the same, we're all human, we all have the same problems, so let's have one system to try and address it. I'm just going to stop there, and I'll happily answer questions.
Okay, thank you, Des. And I think it's quite interesting that you raise the sort of state of crisis that exists in both systems on this island. And I think really the only way around that, certainly from what we've received from people that have joined the campaign and the feedback that we've gotten, is like a better funded system, and a system on an all-Ireland basis that would have that would actually work and be able to work to, I guess, greater efficiencies. When you have a single payer type system, there's certain efficiencies built into that, and it's really the only way I think that we can transition to do something more equitable and universally accessible. So thank you for that. I think next up tonight we'll go to Dr. Lee Humber. I mentioned that Lee is a health and social care academic working in Britain at the minute, but he's just written a really interesting book, Vital Signs, discussing, I think, some of the stuff that Goretti got at in her introduction around health inequalities. But most significantly, he devotes, I think, 2 or 3 chapters to the moment that the National Health Service was founded in Britain under this principle that health and social care should be freely accessible to everybody according to medical need from the cradle to the grave. So that kind of really progressive idea is something I think that has a relevance now with a lot of people. And this notion that there's to be no going back to the sort of failed system on the island has caught on with a lot of people. And hopefully maybe there's historical parallels that we can draw from. So over to you, Lee.
Connor, and I want to start really by saying that the prospect of an all-island National Health Service is fantastically exciting, and my best wishes to everybody involved in the campaigns over there. And if there's anything ever I can do to support that, then I will do my utmost. I want to make 2 brief points, really. Based on a kind of a historical analysis of the setting up of the National Health Service and health in general, as Connor quite rightly said, picking up on some of the points that Goretti made. The 2 points being that it's a fact that a mix of a public health service and a private health service doesn't work. It doesn't work in terms of developing good health for the population. It works in terms of generating profits for the people who run and own health services, but it doesn't work for the rest of the population. How do we know this? We know this from contemporary and historical evidence. So if we want to look at this sort of, if you like, the clearest illustration of this mix of public and private, then we need to look no further than the United States of America, where we've got a private health service which is incredibly profitable. Three health industry corporations are in the top 10 earners of corporations in the United States. So health generates vast profits, but at the same time as that, the United States, apart from having a most profitable health service, it's probably got the worst one in the world. So we've got a situation in America where, and the majority of the population haven't got, they've either got no health insurance coverage because they can't afford it, or they've got inadequate health insurance. We've got a situation where people who are covered by health insurance, the costs of that are spiraling year on year. It's now equivalent to having like a second mortgage for people who can afford health insurance in the States. America spends a greater percentage of its gross domestic product on health than any other country in the world. I think twice its nearest rival, something like 20% of its GDP, and still fails to adequately provide. So that mix of public and private just doesn't work. We can see this also in history, and as Connor said, I wanted to talk a little bit about the setting up of the National Health Service. Pre the National Health Service, during the 1930s, we had a situation where there was a mix of public and private. Again, the public end of things was totally inadequate. I've got a little quote here from the 1930s. There were local authority hospitals tied to outworn boundaries, receivers of all the unwanted and uninteresting chronic cases, still flavoured with the stigma of the poor law, often badly equipped, etc., etc., etc. You can see what I'm driving at. It was a end of the line type of service pre-war, 1930s. In the UK. Meanwhile, the private hospitals, the so-called charity hospitals, catered for those who could afford to pay for the services. So we had a 2, maybe a 3-tier health service during the 1930s. Out of that, and out of a recognition that service wasn't adequate, pretty much in many senses similar to the kind of steps that the pandemic has brought into place in your own country, in Ireland, a realization that this service is inadequate. Out of a realization that you got some fantastically insightful visions of what a health service could look like. Now, I think there's any number of important points about that. First important point is at the center of generating the sort of ideas and the, if you like, ideological context in which a National Health Service developed during and after the war. That context was very much set by the far left. It was an organisation called the Socialist Medical Association, writing in 1932, who first set out a vision of what a National Health Service should look like. Now, I think that's very, very important, because what they talked about was their vision was fantastically visionary. It was about a health service that was community-based, that stretched out into the community, served the needs of the community. It was a health service that was free, obviously. It was a health service that had a salaried staff, no question of consultants going off and earning more cash on their own and enough money to pay for the Lexus and stuff. I saw that quote earlier on in the week in one of the Irish papers. None of that. It was a salaried staff. It was democratically controlled at local authority levels. In other words, this was a very left-wing vision of what a National Health Service should look like. So I think that's the first important point. At the centre of what ended up as the National Health Service some 15, 18 years later was a determined minority socialist organisation. That's fantastically important. People might be aware that 2 years ago there were wide-ranging celebrations of the National Health Service. It was set up in 1948, and so the National Health Service was 70 years old. In fact, before the National Health Service, which was brought into law in 1948, there was a National Health Service in Britain. It was called the Emergency Medical Service, and that was set up during the war, and that very much followed the sort of visions that the Socialist Medical Association talked about. It was local authority controlled, it was a salaried staff, etc., etc., etc. So if you like, it went through two phases, and in many respects, and I argue this in the book, in many respects, the one that passed into law in 1948 was to an extent a retreat from what we'd had during the war. In that local authorities gave up leadership, and that passed back to what has become known as the vested interest, the Royal Physicians Society, and those sorts of people. It's no longer salaried staff for everybody, etc. So it was a retreat. So although we continue, and quite rightly continue to celebrate this free at the point of delivery, and it's something that is very, very close to the heart, that is recognised as something that was a major step forward for working people in Britain. We still celebrate it. In a sense, it was a retreat, and I think that's something to think on, really, because clearly you've in Ireland you've made massive steps forward. And so I'm very confident that, having met Conor recently, I'm very confident that you can push forward on that. Now, the second point I wanted to make, so that was long drawn out first point about public and private not working. The second point I wanted to make was to pick on something that Goretti said, because I think it's fantastically important. A health service is very important, but it is one of a number of what Conor referred to as social determinants of health. The National Health Service after World War II was part of a long period of health improvement for the British population. The extended life expectancies that were in place up until very recently, when life expectancy has again begun to decline, they weren't just based on having a national health service. They were based on the social conditions that occurred post World War II, and those conditions included things like a long, drawn out and consistent program of building council houses. Everybody was homed. There were not everybody, but lots of people were homed. There were vast improvements in people's general diets. Diets improved for some people. Diets improved during the war, which tells you something about how poor diets were before. But certainly afterwards, diets improved on through into the 1970s, when we got to the turn to hyper-processed foods, and diets started to deteriorate again. So the point I'm making is, yes, fight for a health service. Definitely, it's a massive step forward, but also fight for a health service in situ, as part of this general body of improvements in the social determinants of health. And the social determinants of health isn't some sort of backwater idea. This is the idea that is championed and pushed forward by the World Health Organization. They've championed this over the last 20 years. The idea that our health isn't an individual experience. It's not about us versus viruses and disease. It's a collective experience. It's about how social and natural environments and contexts are constructed and maintained in order to defend and promote good health. So as I started off by saying, the very, very best of luck with this campaign, and anything that I can do to help, I will do. But I think, those considerations about the left-wing ideas being right at the centre of it, taking care that something that is set up doesn't get wound back when the immediate crisis is falling away, and a health service in the context of a general improvement in the social determinants of health, I think are important issues to think about.
Thank you, Lee. That was really useful, and I think that historical insight is very important, because again, I've said it again, that we are living in a very unique moment. First of all, I think we've seen that the government were forced to acknowledge how inadequate the public system was, and how it couldn't meet the immediate demands of the pandemic, and then further and acknowledge that the best way to care for people got infected with COVID-19 was to treat them according to medical need rather than their insurance status. So there's a kernel there that I think is very important to hold on to. And now that we see, for all its problems, the private hospital deal is going to be finished, I think that we have to be quite firm as a campaign and call for kind of an extension of that deal and in our view, the nationalisation of those private hospitals. Again, private medicine in Ireland really only exists off the back of the public system, and really only exists because of the deficient public system. We have a unique, I think, a unique situation where people pay for a public system that we all have access to, but you also have 45% of the population paying for private health insurance because that public system is inadequate, and the waiting lists and all the other problems that exist in people's view aren't good enough, and they demand access to private system instead. So for our final speaker tonight, I'm very pleased to introduce Professor Veronica O'Keane. As I said, Veronica is a practicing psychiatrist in Tala University Hospital, a professor of psychiatry in Trinity College Dublin. So Veronica is a member of our campaign organising committee as well, and she's been helping us so far with the campaign. So over to you, Veronica.
Hello, everyone, and thanks very much for giving me this opportunity to speak. I feel very passionate about this topic. It's bothered me for a long time. I've been working for 37 years in medicine, and most of those years have been at a consultant level. I'm on my 5th consultant post now, 2 of which were in the NHS, 1 in London, 1 in Cambridge, and I've had 3 in Dublin. So I know both systems very well. They both drive clinicians mad in different ways, but certainly there's something in the NHS that we lack in Ireland, and that's, I guess, what I want to talk about. But by the time I went to the UK, the NHS had begun to fall apart because of Thatcher. Basically, what she did was she made the hospitals into factories where GPs could buy services, and they were called, the hospitals were called service providers, and the patients began to be called service users. I don't like this language because it is the language of capitalism and industrialized and capitalist medicine and the healthcare industry. Patients don't like it either. I don't mind if people call patients clients, depending on your background, but so that's where all that language started. This created huge difficulties in the NHS, and I think it's very important that we don't go down this road because we tend to follow the mistakes that the NHS makes, unfortunately. So one of the lessons that was learned from that experiment of creating a healthcare industry that was also all owned by the state, in a sense, was that it became evident that the sort of complex care that some patients need is not economically, those hospitals that provide the best care, if you like, for the most complex cases, that they fare very badly in terms of the amount of money they spend compared to, say, for example, a hospital with very low level of expertise that does 100 hips a week and, 100 tonsils a week. If you have an acute hospital with a lot of specialist care taking in very serious head injuries, well, they're going to cost an awful lot more money. So, I'm just saying these things because I think these will be arguments that we will possibly come up against and models that might be introduced and suggested to us as a replacement for what we have at the moment. But the really big difference in terms of working on the ground between the NHS and Ireland is that there is a deep and enduring commitment to the principles of equitable care and free care in the NHS that isn't in Ireland. I'm just going to throw that out there because my view is that our main obstacle to working towards this fantastic goal, which I'm 100% committed to, is the privatisation of medicine in Ireland is socially acceptable. And it's socially acceptable at all levels, even among those of us who, are socialist. So it's a very difficult system to shift. And it's been there since the foundation of the state. I would just recommend to look at the origins of all this is Sarah Burke's, I'm sure this has been referenced previously, Sarah Burke's book called Irish Apartheid, Healthcare Inequality in Ireland. It was published in 2009, and basically she looks at the foundation of the state and how the religious institutions provided the framework for the hospitals and the schools, and they gave sweet deals to the consultants to allow them to have, if you like, ideological control of the hospitals and the schooling so that people would be educated with Catholic ideology, and we wouldn't get things like abortion or even at that point, obviously, contraception. So we are the inheritors of that healthcare system, whereby the nuns really were giving the consultants sweet deals, and that's it in a sentence. Now, people who are very smart and very powerful, like people who rise to the very top of medicine, those people will not give up their privileges easily, and that's just a human trait. So we are fighting against something that is inbuilt into the Irish system. And I think a very good way of looking at this, and it's not a complex report, is the De Butler report in 2019 that followed upon Slowing to Care that was published in 2017. And the De Butler report talks about, and I think it should be a real foundational issue for us, is removing private practice from public hospitals. Really, nobody can disagree ideologically with that. Nobody can say, oh, I oppose that. There are no moral grounds, if you like, for opposing that. So I would say to everybody, if they want a synopsis of that, you can just, the first few pages of the De Butler, BUITLEA report in 2019, you should have a look at that. And basically, in essence, what they're saying is that consultants who are appointed should get public-only contracts. Now, you may think that there are public-only contracts now, but there aren't really, because even Contract A allows you to do private work in a public hospital. I think all that should go. We should have a complete severing of private healthcare within our public system. And that's a simple message. It's simple, it's self-evident, and it's fair. And at least if we're arguing that on moral grounds or in practical grounds, I don't think we can get much opposition from that. Sorry, I'm on call and my phone has just gone off, so I'm going to turn it off and finish in a few minutes. The other thing that I wanted to say to you is that there's a lot of talk about consultants. And consultants are a greedy group, and they are a very powerful group. And it's very difficult to change a healthcare system without getting the consultants on board. But I think you should not forget that our primary care in Ireland is private healthcare. And we, GPs are entrepreneurs. And that's it. Now, most of them do have contracts with the state to provide health services for people who can't afford them. But obviously, the eligibility for a medical card is very low indeed. And then people over 70 or 65 possibly have free access to primary care. Slowing to Care, to its credit, has said that they want to work towards a situation where everybody has free access. The whole public has free access to primary care. And that is going to be a very big challenge. There's this kind of tendency to talk about primary care as if it's, of a different nature to consultant care, and that one is industry based at the consultant level, and that the other is based in, you know, really good principles like public health care, all the things that Goretti and Lee were talking about. But that is not the case. You can't go into primary care and do, for example, studies, which we do need to do, because they are private industries and the GPs are entrepreneurs. They all have their own books. They have their own very complex systems that are very anti-social in my view, because, for example, the state employs primary care healthcare workers, and they have primary care groups. Now, the primary care groups would consist of social workers, psychologists, and when they have meetings, the GPs don't come to the meetings. I went to a primary healthcare meeting when I came back from London, and I was the only doctor at it because I wanted to discuss a patient that primary care were a mutual patient. And I was looking around the room saying, like, you know, where are the GPs? GPs don't actually participate a lot of the time in public healthcare. So we have a very big obstacle, ideologically obstacle, and also very, very much embedded in the financial systems. So the last thing I'm just going to say is that I think that in terms of a way forward, things that we can do immediately, we can jump on the De Butler report and look at their recommendations. These people have worked out what should be done and how to do it in terms of distangling public, private, bringing out the private healthcare from the public system and giving it back to the public. And it's a very, very good analysis. So I think we should spend some time looking at that. And I think the other issue that we should look at is Sláinte Care itself. I mean, Sláinte Care is what we want. The good things are about it, but they're saying, you know, it should be, healthcare should be universal. There should be low or no charge. It should be primary care based, prevention based, based on the needs and the, obviously the concentration of resources should be in the areas of greatest needs. And we need very practically an IT system. There's no IT system in the HSE. So the bad things about Sláinte Care that we can, where we have the advantage, is that they're saying it'll take 10 years to implement them. And it also requires massive workforce buy-in. I don't think we're always going to get the workforce buy-in. So I think it does need strong leadership and some imposition of things that people may not initially feel comfortable about in the workforce. But I think we have a momentum now. We can jump on that momentum and, you know, really use this occasion to bring to the attention of the public the inequities. Okay, that's all I have to say. Thanks.
Thanks, Veronica. It was really insightful. Actually, I think the analysis that you gave of the De Butler report, and I think absolutely that has to be one of our, I think, immediate demands. And I really have to wonder about the viability of private medicine if you were to remove private medicine from the public hospitals and maybe to remove some of the other subsidies that it depends on. I think people sometimes don't have a proper conception of just how much support the state gives to keep the private system going, and that without that support it probably would be inviable. So that's an important point. And also on GPs, which I might actually come back to with a question we have from the audience. The first question I actually want to go to, and I'll put this to the whole panel, so feel free to come in, just signal, is from Marnie. So this is an interesting one that we didn't touch on. So in the UK post-war, it was socialist doctors who pushed for change, as Lee said. Here it would seem that it is users of the health service who are most desperate for change, as are the nurses and healthcare workers. How much do the panel think that getting doctors on board will be important? And I actually might broaden that one out a little bit as well. I think just healthcare workers generally, maybe. We heard through the pandemic that actually there's still quite a number of nurses who haven't gotten the new pay deal that nurses won with their strike last year. And there's obviously issues as well for healthcare assistants and other auxiliary healthcare workers and allied healthcare professionals. So what do people think the role of healthcare workers would be in achieving reform for the system or a national health service?
And maybe I could jump in there. I think that healthcare workers will be a really important force in terms of the campaign, and because they're a very important voice, and people are hugely moved, I think, by the work that they do. Healthcare assistants are the people who are absolutely floored to our shame by this pandemic. The people who are the lowest paid in the nursing homes were the people who bore the brunt of it, apart from patients, obviously. So I think people feel very emotional. I think we all do, about those low-paid healthcare workers. So I think they have a very important voice in terms of activism. In terms of moving things on, I mean, it's great that there's another socialist doctor there, Des. We're definitely a tiny minority. So I think it is hugely important to get as many doctors on board as possible. The guys at my age, I'll do my best. I'll leave it at that. But, it is important, but and that's going to be, I think, more behind doors stuff and creating a public drive to create a contract that absolutely excludes any private practice, public only. And we don't have that yet. We do not have that.
Thanks, Veronica. Des, do you want to come in on that one as well? It seems it's directly kind of relevant. I guess as well, just to mention, maybe some of the drivers. I think a good friend of mine is a young doctor who's actually on a GP training scheme at the minute. And he mentions some of the problems around kind of getting permanent posts and some of the other sort of uncertainties that young doctors and healthcare workers face. So maybe you could give us your insight on that.
Well, I'll just start first of all by saying, like, a lot of the healthcare workers, whether they're doctors, nurses, porters, radiographers, whatever label you want to put on, everyone is important to get a change for a new health system, and everyone that I've spoken to about it over the last couple of years is behind us, even though they might not be publicly willing to speak out. When I first decided to start talking about this sort of stuff, consultants within the hospital I was in said, look, it's not a good idea, it's not the done thing, you might not get into training schemes, you might not get recommendations or references, it doesn't really matter. As a doctor, to be honest, any healthcare worker probably has a little of a socialist bone in their body. Why else would they care for people they don't know? So, like, a lot of the people that I trained with or worked with ended up leaving the health system because of the conditions they were in and going to greener pastures, whether that's over in Australia, New Zealand, or over in Scotland, England, or Wales, or some went back to the States or Canada where they were from. But with this pandemic, they returned in their droves because they wanted to come home and help. And with that support, people coming home wanting to help, that shows that if we want to change the health system in general, the support will be there. Otherwise, they wouldn't come home at all. And then with regards to permanent and salaried jobs, I don't see a reason why they shouldn't exist, because I think people's whole thoughts on a work-life balance and training schemes will probably change after this pandemic is over as well, because they want to finish their training and maybe stay at home closer to their family. So why can't training positions be created in their local hospitals? And then that might, like, okay, I can't speak about this because I don't know enough about where people are from or how populace live in different cities, but if the same opportunities are available in people's own home cities or towns, they'd be more willing to stay there instead of being under the impression that they have to go and work in a huge hospital in a huge city to get world-class training. Whereas this island is so small, why can't we offer salaried permanent training positions in people's local areas to retain them there?
Thanks, Des. I think the point you make about that return to help, or that willingness that so many healthcare workers had who were working abroad to return and get stuck in at the coalface is really inspiring. But another friend of mine who's a nurse that responded to that call for Ireland was shocked when she heard that she was going to be hired through an agency rather than directly hired to the HSE. And again, this contract that they had is for a fixed term. It didn't cover things like sick pay, and she ended up actually getting COVID herself while she was working. I think that just shows, while there is a tremendous goodwill from our healthcare workers, that the system just isn't supporting to give the care that they want to give. So I might get Goretti, do you have any thoughts on that question, the role of healthcare workers in the campaign? And Lee after, perhaps.
Yeah, I do actually. And I mean, there's a couple of things. So first of all, I'd like to agree with Des that I think that there's more of a willingness there, certainly in the north, from doctors who are consultants. I'm actually talking specifically from Derry, right? I don't actually know what it's like in Belfast so much, but because my daughter's severely disabled, I see a lot of consultants with her, and I am constantly impressed by the way in which they say, they will say to me, I don't have private patients. I don't agree with people having private patients. Now, there's not a big market in Derry for private medicine because there's a lot of poverty here, but there is a market. Like, I mean, there are, there's enough people who've got some kind of decent wages. But I'm just been really impressed by that. And in fact, one of her the pediatrician that she had, like, obviously she's moved on from that now, she's an adult, but the pediatrician actually resigned because he was so disgusted with the way in which the NHS was going, So I do think that there is, even with doctors, and I understand, Veronica's point, because especially in the south, it does seem like, that thing that Nye Bevan had, but you have to stuff their mouths with gold in order for them for doctors to kind of be willing to be part of the NHS. Our GPs up here are all independent businesses, but they really are businesses, even more so than in the south. So, like, they have these GP federations. They're being encouraged to build new buildings. And the minute that you hear people building buildings, like anybody who works in university knows this is the downward slope, from the workers' point of view. But actually, when you talk to them, they all hate it, and it goes back to work-life balance, because they say, I came into medicine because I wanted to be a GP, because I wanted to help people, and I've ended up having to do accounts, and I've ended up having to worry about how am I going to pay the mortgage and all this on the building, on the surgery building, and I'm worried about being an employer rather than actually doing the medicine. So I think that actually I think that it may well be that if there was an offer of a really decent health service where they were salaried workers and actually would be guaranteed a work-life balance, that there might actually be a very different approach from doctors, especially. And I mean, we are going to have some stage have to talk about this. How do you get that kind of NHS, across the island? We're not going to get it just by signing petitions. It's not going to come from the goodness of their hearts. It is going to come as part of the kind of wave that we saw, how we won abortion rights. I am going to keep on coming back to that. Coming back to how we won the abortion rights, because like, we never thought we could do that on the island of Ireland, and yeah, we're still waiting to get services here in the north. But the idea that across the island of Ireland that abortion is now legal without reason, for up to 12 weeks, and then after that, on the kind of basis up here and kind of basis in England, I thought I wouldn't see that in my lifetime. How did it come about? It came about because of a huge social movement, because of a mass movement, really, and we are going to need something like that in order to get the kind of NHS that we want, I think.
Thanks, Goretti. Just on that note, as Goretti's very eloquently put, I think we will need to build a movement, and to do that, we'll need to build groups all across the country that will actually serve as, I guess, representatives of this campaign on the ground. We need to, I think, mobilise very quickly if we're going to take advantage of this kind of unique situation. So, if you go to the comment section, you should find a sign-up link pinned at the very top. We had a great response at our last meeting, and actually we're able to grow an organising committee out of that call. So I'd really encourage people, if you have any interest in getting involved, please fill in that form and we will get back to you. And even if you want to be kept in the loop of what we're doing, I'd encourage you to fill in the form. So I might go over to Lee there, because I think that Lee might have something interesting to say on that need to mobilise and need to actually fight for an NHS style system.
Maybe you can confirm that or not. Yeah, fantastic potential, I think, in terms of healthcare workers for any number of reasons, some of which I think Connor and Des both alluded to, really. Healthcare is changing. The way healthcare is done is changing. And so healthcare workers' conditions of employment are changing. People might be aware that 3 or 4 years ago, we had a series of strikes by junior doctors in the UK in response to the fact that their wages and conditions were massively under stress. There is a movement globally at the minute in terms of putting medicine online, video calls for doctors' surgeries and all that kind of thing. That's going to have massive effects on the employment conditions of doctors. And Connor alluded to the fact that people weren't getting paid, the contracts weren't getting paid, they were paid via somebody said that people were being paid by an agency. All of this stuff in the context of people putting themselves at risk on the front line on a consistent basis to, basically make sure the country can keep going. Once that genie is out the bottle, once it's been recognised that private healthcare is not adequate to deal with these sorts of crises, it's going to be very, very difficult to get that genie back in the bottle. We talk about the National Health Service. Nobody, the powers that be who passed the National Health Service into law did so with gritted teeth, and they've been trying for the next 72 years to get that genie back in the bottle. They don't like the fact, the private healthcare companies, even the government ministers, the health ministers, they don't like the fact that there aren't massive profits being generated from the health service. They want that back in the bottle. It's very, very difficult. Once it's out, once people can see that's what we need. We need a public health service, and this crisis shows very clearly that we need a public health service. Then it's very difficult to get that back in. Second, just the second thing two more very brief things. First of all, in terms of the NHS and its setting up, it's certainly the vision, and lots of the arguments were carried forward by socialists and socialist groups during the war and afterwards, but it was built and passed into law on the back of the fact that the working class in Britain during the war and afterwards was massively well organised, really strong. During the war, trade union membership in Britain rose from something like 6 million to 9 million. It was an organised, angry working class who demanded stuff. The working class was not going to let the ruling class get away with reimposing what was in place in the 1930s, this split between inadequate private healthcare and very inadequate public healthcare. So it's very important that organised workers are at the heart of this, in my opinion. Then the last thing to say, I think, is, look, we've been through 3 months now, 3 or 4 months of the pandemic, and the world has been turned upside down. Billions of pounds, trillions of dollars have been found suddenly to pour into the pockets of industry to keep industry going. Once you've seen that going, then, you know, if the pandemic ended tomorrow, and in the UK, if Boris Johnson said, "Oh, we haven't got any money for the social care," well, he'd get laughed out of court. Well, what about the billions of pounds that you just put into the pockets of? You see what I'm saying? So the depth of how deep this crisis goes, nobody knows how deep this crisis is going to go. It's obviously going to flow from a health crisis, and already is flowing from a health crisis into an economic crisis. The deeper that crisis gets, the less hold the old ideas have a purchase. They lose purchase on people, ordinary people like us, and they lose every time a politician or somebody from big business mouths the old way. They look a fool, you know. So it's organised labour definitely at the centre of it, and these sorts of crises. There is an approach, isn't there? We talk about dominant paradigms. The dominant paradigm in Ireland up until a month or so ago was that we had a private-public split. That dominant paradigm for this at this moment in time has broken down. So now it's up to, can we sustain that, and rather, can you sustain that, and can you move it forward?
Yeah, that's a really good way of putting it. I think a lot of the old certainties have kind of fallen asunder in this moment, and like all of these things that they told us were impossible before COVID have now happened. That where there was no magic money before, we've suddenly discovered a whole forest of them. And here, I think in the health service, we've lifted a recruitment embargo that was apparently impossible and intractable before now, and we also significantly had the takeover of the private hospitals. So I think we really can't. Poverty of ambition here is the worst enemy, and to set the sights high in the period ahead, and to really ask what we care about as we're facing into an economic crisis. What do we really value? I think is an important question moving forward. So I just want to bring up for a second a comment from Kelly, who left one earlier. So Kelly, I believe, is a dentist. And she makes, I think, an important point here for the campaign to take on board. It'd be amazing to see oral health care included in the objectives. General health and dental health are closely linked, and the private dental sector is not unlike the GP system. So I think that that's absolutely true. And actually, Kelly, I'd encourage you, if you're still watching, to fill in the form above, because it'd be really useful to have your input on that as we move forward. Next, I want to bring up just a question from Owen about junior doctors that I guess we kind of gotten at before, but maybe it's worth a bit more of a conversation. So this one here is, can we talk about the proletarianization of junior doctors? So a fancy word there, I guess, but and how they could be a potential civilizing force in the medical profession by uniting with other wage earners in the hospital. So I think really one thing that's important to raise here first is that the model of general practice in Ireland is changing very, very quickly. And I've talked to Owen about this before, who I mentioned earlier on as a trainee, as a GP at the minute. And there's these groups like Centric Health Care, which are owned, I think, by, funnily enough, the Rothschild Bank. That's their major stakeholder. And what they're trying to do at the minute is to buy up, I think, GP lists, access to GP medical card lists. And it seems that they're trying to, there is a force at play here that is turning doctors into workers anyway, but doctors into workers for these massive kind of capital intensive bodies rather than for a public system. So maybe if we could come at his question here. Des, do you have any thoughts first? It's
a very complicated question, to be honest, because like the last thing I want to do is work for some massive organization and be a faceless employee and just see random patients every day. And you could maybe argue that, oh, like that's working in an emergency department, people you don't see ever coming in and you'll never see them again. But what you're suggesting is buying up these huge lists. Like, for what end? Is it just to make money, just for profit? I don't think junior doctors have any interest in doing that. Otherwise, they wouldn't leave to go work somewhere else where it's better and then come back even if the situation is bad here. Like, it's definitely something we'd have to be worried about, but I don't think you'll find a lot of new graduates wanting to sign up to an organization like that at all.
Thanks, Des. Goretti, do you want to come in on that one about doctors being and healthcare workers being a potentially civilising force as we move forward?
Yeah, well, I mean, I think to be honest with you, I think we kind of answered it already in the previous question. I mean, clearly we saw during the junior doctors' strike that term proletarianization, that they are actually becoming more and more just like ordinary workers, being treated like shit, expected to work long hours, not being paid very well, so they really have become the junior doctors just like the rest of us. I one of the things I would fear is that I see this in the universities. You're a temporary worker, a contract worker, early career researcher, whatever, for years, and you're working on temporary contracts, and you're just trying to get something permanent, and then you get it, and you see so many people who then stop worrying about all of the people who have the same shit contracts that they and working conditions that they had until last year, and really don't see it as important. So I worry that may be something I've actually heard during the junior doctor strikes. I've heard on the telly, like English consultants saying, well, we had to do it, so why shouldn't they? So there is the fear that when people get to a certain level, that they forget what it was like themselves. So again, it goes back to this thing I think about, that I think that we will do this as part of, I think we have to think about things in a completely different way and stop thinking about the way that things are organized at the minute and seeing how we can tinker with that in order to improve it. I think we need a whole new, we need an empty slate, an empty blackboard, and actually let's start from scratch. Let's start from here.
Thanks, Goretti. Any thoughts on that one, Lee?
Really interesting, and your example of the Rothschilds thing is absolutely fascinating. Let's be clear. Every single aspect of the health industry, every single aspect of it, whether that be health insurance, hospitals, drug production, research, every single aspect of it is monopolizing. There has been the last 10, 20 years, huge movement of acquisitions and mergers. You're getting fewer and fewer, bigger and bigger and bigger companies. And of course, that unless we fight it, that is going to happen in terms of health, in terms of who employs doctors, and it's going to have a massive impact on conditions of employment. I've just because I've just been researching this a little bit, because I've just written something on vaccine production. There's a drugs company, UK drugs company called AstraZeneca. Over the last 20 years, they have gobbled up, I think it's 17 other drugs companies. They're getting bigger and bigger and bigger. They're currently producing a vaccine in collaboration with Oxford University. The reason they're doing it with Oxford University is because they've junked their own research and development thing, and now they outsource it to universities, which saves them lots of money. They earn their money by selling drugs and buying up other companies. This is the model. This is the trend, and all of that monopoly control of the way health is done, that's going to have a massive impact on every aspect of the medical profession. I suppose there'll be the higher echelons of the medical professional. They'll benefit from it financially. Everybody else, unless you're organised and you fight back, you'll be, the exploitation rates will go up. That's the pattern.
Do you want to come in on that one, Des? Is that you indicating there?
Yeah, please, if you don't mind, just to follow up on what Goretti and Lee have both said there, because he's quite right. Everything is being monopolised, and Goretti is right. We need to have a totally different approach to this. But we've already seen that happen with this coronavirus pandemic. We've had people making medical products off their own back and donating them to hospitals that are local to them. We've had face visors that were made, scrubs, masks, all sorts of stuff, and it was just donated, instead of having to rely on poor quality masks produced outside of the country. And unfortunately, we're actually still using incredibly poor quality masks in the emergency department now across the country, across the entire island, not just the north or the south, but across the entire island. Very poor quality material that was sourced from elsewhere. And unfortunately, why weren't we making that here? We have the ability to make it here. We should be making our own supplies here, to be honest.
Absolutely, and I think that's really borne out in the scandalous healthcare worker infection rate that we had in the south, approaching, I think, 32% of healthcare workers were infected because they couldn't get access to appropriate PPE. There are plenty of places where we make industrial garments, all of this sort of stuff that could have been repurposed for the pandemic. Yeah. And I think that we have to seriously look at how we provide for our health needs after this. Just before I let you in, Goretti, I work myself as a research assistant and kind of translational scientist. And it really strikes me, that point that you raised, Lee, about how so much kind of useful, I guess, knowledge and useful innovation is actually stifled by the commodification of healthcare, and how you're forced as a scientist, if you've found maybe promising treatment for something, to go to the likes of AstraZeneca with that idea and sell your intellectual property, that there is no way of developing or innovating publicly when it comes to drugs or vaccines. And it means now that we have a tremendous shortage of vaccines. The vaccines that were being developed for the SARS epidemic in 2002, 2003 were shortly dropped after that the immediate threat of that pandemic was finished, because they weren't profitable. So everything, I think it shows that when you treat healthcare as something to be bought and sold and paid for, it serves no one's interest, neither patients nor people working in the health service. So Goretti?
Yeah, I was on that point that I wanted to come in, because if we look at how the vaccines for things like smallpox were developed, it was because of cooperation between scientists. And I'm just really struck by how many of these big pharma companies actually have operations in Ireland. So ideally what we would do is, we'd force them, the government here would force them to sort of say, if you want to stay based in Ireland, if you want to keep your profits being channeled through Ireland in order to pay as little corporation tax as you do, then you're going to have to cooperate with each other on getting this vaccine. You can't just compete in it. That's the kind of thing that if health really mattered to governments, that's what they'd be doing, I think.
Absolutely. I'm quite conscious of the time now. We're over an hour and 10 minutes, so I might take we have time for maybe one or two more questions, and then I'll get you all to maybe sum up. I guess we'll go to one from Chris Carroll here. So Chris says, hi all, many thanks to the great speaker. I wonder, would it be possible to ask the panel about the role of theory within social movements to produce this paradigm shift necessary to move to a different type of healthcare and public health? Do we need to worry about things like internal markets and methods of resource allocation, or is it more important to advocate for improved access to universal healthcare? So how much detail do we need, and how much do we have to concern ourselves with theory here? I might go to you first there, Goretti, since you've been involved in the campaign since the start.
Yeah, I feel very strongly that we shouldn't get bogged down in detail. I think that our focus really has to be on very simple ideas that people can understand. And actually, I think I see in some of the comments that people are asking about, should we be looking at a German model? Should we be looking at a French model? I really would think, no, we shouldn't be doing that. And the reason is because people across the island understand that the NHS means, free at the point of use, means that, you don't have to worry about paying for anything. An awful lot of people forget that we do actually have to pay for things like dental care. They forget that we do have to pay for, glasses and eye tests and stuff like that. So, there are things we do have to pay for, but the general view is, the NHS equals, free healthcare for everybody. No need to worry. No need to worry about money when it comes to looking after your health. And I think that actual idea is the ideal of the NHS that we're looking for. We're not looking for an extension of the NHS that they have in England, which like seems to be worse even than it is here in Northern Ireland. We're not looking for the NHS that there is today. We're looking for the NHS that people fought for in 1945, the NHS that people actually, saw as the great golden dawn, which it was actually. And I think that that the reason that we should be doing that, I mean, there's another more political reason for doing that in relation to the fact that this is an All-Ireland campaign. At the launch meeting, Fintan O'Toole said something that I think is really important. He said that the great thing about having a campaign for an All-Ireland NHS is that and we've always sort of said that this campaign was a campaign of a united Ireland rather than for a united Ireland. But he made the point that actually for people who identify as British in the North, and some of my best friends identify as British rather than Irish, for them then to be looking at, becoming part of a 32 county Ireland, of a united Ireland, that they know that because we're bringing the NHS, because we're insisting that we have an All-Ireland NHS, that they know that their rights will be protected and vindicated within that All-Ireland kind of setting. Now, when he first said it, I was like, I kind of thought, that's a bit weird. But I did actually mention it to my friends who think of, who are socialists, who are even revolutionaries, but do actually think of themselves as British, which seems like really weird, I know, but they do. And when I said it to them, they were like, oh yeah, that makes sense. And they could see that, do you know what I mean? They could see themselves being like, anyway. So I think that it's quite important that we keep it simple. And yes, we do need to talk, of course, about the theories within social movements. But I think that we shouldn't get caught up in minutiae of, what the kind of health service issues are. It should just be, build the biggest mass movement that we can, that can actually win this kind of NHS.
Thanks, Goretti. I think, just while you were saying it there, an interesting example of another really energetic health campaign we've seen in the last couple of years came to mind, and that was the movement kind of popularized by Bernie Sanders in the States, Medicare for All. That really simple kind of slogan that catches the essence of, I think, universal access that based on need rather than ability to pay. So something simple can have a great resonance, whereas I think, if you look at Sláintecare for All, its laudable conclusions, it just doesn't have that same potential to mobilise people and actually deliver. Des, do you want to come in on that one, and then maybe Lee after?
Yeah, I'm just going to follow on from what Kelly said there, and I agree with it completely. Like, we can go really simple with this or really complicated. If you want to go complicated, like I'm a product of society now up here in the North. I come from a mixed background. I've been to schools on both sides of the educational divide. I've been to universities in both the North and the South now. And what I can tell you is we really are all the same. Patients that I've treated in the North and the South are the same. They have the same problems. People I've spoken to in the last couple of weeks and they've asked for advice, like, how long should I self-isolate for? What's the story now? And I'm saying, look, we're getting so much conflicting information from Public Health England and from the South. And I just tell them, follow what you want. And they turn around and go, look, I've been listening to the South because we're all part of the same island. And I will, of course, it makes more sense. And then when I tell them, look, that we just follow the 14 days, you can check both websites if you want every day to see if there's any changes. That there will be, because it changes every couple of hours. But everyone that I've spoken to, regardless of what side of the fence or whatever you want to call it comes from, they've said that they're listening to the advice given from the South. They saw better leadership from the South. Even, in fact, there's now a specialist registrar in cardiology who's resigned from the NHS because of such poor leadership that's been shown from the UK government over there, and that's a shame. Like, imagine losing a specialist registrar, a year probably before he finishes his final exams to get into consultancy. It's not acceptable. It's a huge loss for the health system. And so, just to go, it has to be as simple as possible. We need a health system that covers the entire island for everyone on the island, regardless of what they believe in or who they are, what they think, and it has to be free. If we get stuck into all these details and theory crafting, we're going to contradict ourselves and get confused. We just have to have simple points that should be free for everyone. It should cover everything. There shouldn't be two tiers. You shouldn't be able to pay to get ahead of the queue to receive the same level of care that everyone's entitled to. You should get care in a timely manner and for free.
Stairs. Lee, do you want to come in on that?
Yeah, just really briefly. Yeah, I think I'm just to echo the other two speakers, really, that if things start to get too technical and too internalized, I think that can really disable things. And I say that because people might be aware that in Britain there is hundreds, I think, probably of Keep the NHS campaigns going, and some of the sort of conversations between them and the way they try and organise gets very, very detailed and there's to a certain extent disarmed a lot of what is otherwise good work that a lot of these local campaigns do. So I think there's a real danger in getting too detailed, and so I'd agree that straightforward aims and goals for a campaign are essential. I suppose the only thing that I'd add to that is that it is a lesson from the 1930s in the Socialist Medical Association, really, because they had basically 5 points. The 5 points were it needs a health service that's free, that's salaried staff, it's democratically controlled, it's community-based, it's preventative and curative. Now, I kind of like that level of detail, really, because it strikes me that appeals to everybody. Free, that's patients. Salaried staff, that's you're getting health workers on board. Democratic control, you see what I'm saying? So those sorts of very straightforwardly put, but kind of not detailed, but a little bit more detail than just one slogan, I think is pretty cool. And I say that because, as I said before, the health service that was set up before the National Health Service from 1938 to 1948, that was pretty much along those lines. And so there was a certain amount of, if you like, we didn't want to retreat, but at least there was a certain amount of room to retreat. I suppose what I'm saying is if you've got a vision that is very clear and very progressive, then there's always a certain amount of give. If you can't achieve all 5 aims, all right, well, let's achieve 4 kind of deal. I suppose that's what I'd want to feed in.
Thanks for that, Lee. I have just a comment next from Tom O'Connor that I want to read out. So this one is following what I think this is a comment Lee made earlier on. Following what Lee says, we need to get the Irish trade unions to campaign for an Irish NHS. But COVID means that union conferences will have been cancelled. We need to get activists in unions working on this. So I just want to say to that one that we have actually, as a group, crafted some model motions for people to bring to their own trade unions, not just healthcare workers, but I think trade union members in general. So again, I'd really encourage people to fill in that contact form that we have in the comment section, because that's something that we want to do in the very near future, to get trade unions mandated to support the idea of a single tier All-Ireland National Health Service. So we'll only be able to do that if we grow this campaign. So please fill in the contact sheet there. I think that's we're now at 1 hour and 22 minutes. So what I might do now is I'll go in maybe reverse order from what we started with. So I'll start with Lee, then on to Des, and I'll give the final word to Goretti. If you just want to give a couple of comments to sum up, and we'll leave it after that.
Okay. Yeah, to be honest, I suppose if I was going to sum up what I'd like people to take away, really is pretty much echoing what I started out with. I think what you've achieved so far is magnificent, and it's got huge potential on all sorts of levels, not just in terms of health, but in terms of unity for the island of Ireland and all sorts of political offshoots. It's incredibly exciting. So all power to your elbow, really. I suppose other than that, I think I'd like to stress the lessons that I've certainly drawn from the history of the NHS in the UK is the centrality of that very clear political focus right at the centre of any kind of campaign. That what Connor just finished on, really, in terms of building that campaign across organised labour in trade unions, is essential. And then the final thing I'd like to say is, again, returning to something that we started off with, is that I think all of us need to remember that a health service is part of an approach to health. It's not the whole story. Yes, of course we want adequate and good standards of health service, but that needs to be part of adequate and good standards of societies generally. That's got to be partnered with good housing, good diets, good employment that doesn't flog people to death so they die 5 years after retiring, kind of deal. So seeing a health service as part of a general approach via the social determinants of health, I think is essential. But listen, really good luck, and thanks very much for inviting me to talk this evening. Really enjoyable.
Thanks, Lee. And I just want to remind everybody that Lee is the author of a fairly recent book called Vital Signs, The Deadly Costs of Health Inequality. And I really recommend that book, not just for its historical arguments, but for how it deals with the question of the social determinants of health and kind of that broader conception of what we need to live in a healthy and fulfilling kind of society. So thanks for that, Lee. Des, do you want to?
There's really not much more I can add to what Lee and Goretti have already said, along with Veronica. We need a simple campaign to push for this, to get everyone involved, public and all healthcare workers. And to be honest, everyone will be behind it if it is going to help them and their families whenever they come to need it. Everyone becomes a patient in the end. That's why we have to advocate for our patients, because we will all become patients eventually.
Thanks for that, Des. Goretti?
Yeah, I mean, again, it's very hard to I don't know if I'll have a lot to add, except perhaps to emphasize that insofar as society is unhealthy as it is, that's actually got a lot to do with the growing gap between the rich and the poor, and the kind of social polarization that we've seen growing in recent decades. And I think that the COVID crisis has really exposed that to such an extent that we have a moment now that we really need to grab. And that's why this campaign is so important, because it's kind of saying, that it's not good enough that we just kind of blame people. I mean, I'm in real danger of starting another rant here now, so I have to be careful not to. But I live with somebody who, when I took up with him, smoked 40 or 50 cigarettes a day, and I have spent the last 30 odd years stopping him smoking, and then this because of because it's going to affect it's very clear it's going to affect his heart, it's going to affect his lungs, all this kind of thing. Then we have COVID and lockdown, and the next thing, there's no air pollution. And the next thing we find that actually there's far fewer heart attacks, there are fewer strokes. The doctors are saying, why are these people not turning up? They're not turning up because they're not having the heart attacks and the strokes, because the air pollution being gone and the stress relief, frankly, of not, I don't know about the rest of you, but I loved the first few days or first few weeks of lockdown, just not having all that stress. Sorry, Des, I realize it was worst for you. But but because of all of that, there was actually less illness, because of the clean air and everything. So that really just sort of says to me that actually the extent to which it's the way the society is organized, and it's the way in which our air is being polluted and our food is being polluted, and just everything that's going on in society has such an impact on our health that, frankly, if I wasn't already a socialist, I'd be kind of going, oh my God, I wonder, do we need a revolution? Because it's becoming clearer and clearer throughout lockdown that actually this is good for us in some ways. That obviously I realize there's mental health issues because of the isolation of lockdown, but in terms of actually the way that society is organized, it's exposed it. It's as if it's pulled off the mask off society. And I think that we really, really need to make sure that like I say, that we grab this and that we use those examples. Do you know what I mean? That we say to people, have you noticed all of this? And then we can maybe make better. But just sort of see somebody saying, sorry, COVID has only reduced CO2 by small amounts, and that may be the case, but actually in overall. But interestingly, I live now. Derry only has 100,000 people in it. Nonetheless, it has the third highest level of air pollution of any city in the UK. Where I live, and where, like I say, actually the average life expectancy for a male is so low that it's actually worse than Glasgow. We actually can notice the difference in our when we're walking. When we go out for our daily walk, we can actually notice the difference in when we're breathing in. That's how bad the air pollution is. So I think that we have to look at the poorest areas as well, and actually say, yes, overall across the whole world, the CO2 hasn't reduced that much, but in the poorest areas, which tend to be the most industrialized areas, which tend to be the most overcrowded areas, etc., in those areas, it's been fucking brilliant. And that fact, and it is a fact, and we can actually see it in the numbers of hospitalizations for things like COPD. Again, this area has some of the worst COPD on these islands, and there's been much less hospitalization for it. And it's not just about people being afraid to go to hospital, and it's actually been because of not having the same level. So yeah, I mean, that I realize that sounds like me just kind of saying, we don't just need to fight for an all-Ireland NHS, that we need to fight for a whole different kind of society. But I guess that is what I'm saying. Yeah,
absolutely.
Thank you, Goretti. I don't think I'll even try to follow that one up. I think you've summed up exactly what we need to fight for in this campaign. And I'd just like to close by thanking, first of all, our panelist speakers tonight. If people were wondering where Veronica went, Veronica actually was on call while she was speaking tonight. So she got a call and had to go back to work. But I'd like to thank her, Goretti, Lee, and Des for their excellent contributions tonight, and also everybody for their contributions in the comment section. And once again, I'd like to encourage people, if you haven't already, please fill in the sign-up sheet that we have in the comment section, and also our petition, which is in the comment section. Please share that one around. Petition's not going to be the basis of a campaign, but it's definitely a start, and it's something that we can use to popularise the ideas of a truly healthy society and an all-Ireland NHS that will be free for everyone to use on the island. So thanks everyone, and hopefully you can join us again for our next meeting in about 2 weeks' time. Cheers.